Good afternoon, everybody. Welcome to the Diabetic Foot webinar. We have two wonderful educators, presenters with us today. I will let you introduce yourselves. Lauren and Ibrahim.
Hi, everyone. I'm Lauren Ross. I'm one of the community podiatrists for Havering and within Delft.
Hi everyone, I'm Ibrahim. I'm a PCN podiatrist working at Havering Crest. Okay, so Laura, should I pass it on to you?
Might help if I unmute myself first. Okie dokie. Can everyone see that?
Yes, it's perfect. Thank you.
Excellent. I'm just gonna. There we go. Okay, so as I say, my name is Lauren Ross. I'm one of the advanced specialist podiatrists. So I work within Delft, mainly Havering, but I do branch out to B&D and sometimes into Redbridge if needed. So today's programme, we're going to be going through the diabetic foot assessment. So looking at the vascular assessments, neurological, having a discussion about foot deformities or common foot deformities that we would see. How often we would do those diabetic foot assessments. I'm going to discuss a little bit on the Charcot foot and then how you can refer if you have any clients or patients that you see that you feel would benefit from having a bit of podiatry input, then how you can refer those patients in. Okay. So as a bit of background, I'm just going to hide that in there. We go. For a bit of background information or a bit of demographic information, the reason we put so much emphasis on the diabetic foot assessments is because around 5 to 7% of people with diabetes will have or have had a foot ulceration, and 80% of non-traumatic limb amputation are preceded by an ulceration. After that first amputation, people with diabetes are then twice as likely to have a subsequent ulceration, and 50% of people will then die after developing a foot ulceration. So it's really important that we put that emphasis on assessing the diabetic foot, highlighting any issues really early on so we can try and prevent those problems from occurring. As you can imagine, that does have a significant financial impact on the NHS, which in, I think it was 2022, a thematic review was published and it estimated a £1 billion spent on ulceration and amputation per year. So it has a real significant impact on the NHS. So how can diabetes affect the feet? So there's a number of different ways, but there's four main ways really that it can affect the feet. So you have neuropathy, and these are all, we're going to discuss these in a little bit more detail, but you have neuropathy, infection, ischemia or peripheral vascular disease, and deformity. So the impact on the diabetic foot. So with ischemia, so that's little or no circulation to the peripheries, and this can lead to pain, it can lead to ulceration, necrosis or gangrene. Neuropathy, which is that damage to the nerves and the nerve endings, particularly in the periphery. This can lead to a change in the foot structure, which can then also lead to ulceration. You have increased callus development, unknown injuries. So a person could be walking around with a huge blister or an ulceration, they don't necessarily feel it. It puts them at an increased risk of developing a Charcot joint and also then ulceration. So what could happen if that does occur? So as you can see, that's the right foot, there's an ulceration. It looks like that in that photo, that patient there has had their 4th and 5th digit amputated, and that has then left that ulceration there. But ulceration can occur anywhere on the foot, in between the toes, heels, everywhere. Amputation, so you can see from that photo there, that patient there's had all 5 digits amputated, so it's a transmet amputation, and that obviously is led with the ulceration there. That's going to have an effect on pressure distribution over the foot, may potentially affect that patient gait. So it has a real knock-on effect to that patient's lifestyle. And necrosis. So you can see from that photo there, there's an obvious colour difference. And that is linked to either infection or poor blood supply that's allowing that skin and that tissue to necrose. So following the NICE guidelines set in the NG19, by completing a quick assessment, we can screen patients with diabetes and determine the likelihood of that patient developing a foot ulceration or a foot condition. The aim of the assessment is to identify if there are any risk factors such as ischemia or neuropathy, deformity, or if they've had a previous ulceration or amputation. And the assessment includes a vascular assessment, so assessing that patient's blood supply to the foot, a neurological assessment, so seeing how much that patient can feel, if they've had any change in their sensation in their feet, and also a visual inspection for any deformities or skin conditions. So vascular assessment. It's something we commonly do every day in podiatry. As you can see from that photo there, I mean, it's quite an old photo. It's like it's, but it's someone using a handheld Doppler. So it's a handheld ultrasound device. So when performing a vascular assessment, we assess the colour of the foot. So is there any paleness or redness? Is there a colour difference between each limb? Is there any like a dusky pink colour, any cyanosis or hemosiderin staining going on? We'll also look to see if there's any hair present on the foot. So you need to have a decent blood supply really to be able to have hair on the feet. So that's a good indicator of that person's vascular status. We'll also look at temperature of the foot. So is there a temperature between the left foot, or a temperature difference between the left foot and the right foot? Is there a big difference between the heel and the toes? And we always like to compare within podiatry. And we'll also ask the patient if they're experiencing any symptoms of claudication. So are they getting that cramping feeling after they walked a certain distance? Is there any rest pain? So are they getting any of that cramp when they've got their legs elevated, either during the day or for night time? So one way to remember the signs of ischemia is to remember the 6 Ps. So again, have they got any paleness? So we're looking at that colour again. Is that patient experiencing any pain? So you can get painful ischemic, that cramping sensations. Pulseless. So can you palpate that patient's pulses? If so, generally their blood supply is okay. If you can't locate those pulses, that does raise alarm bells. Is there some ischemia going on? Perishing cold. So again, that temperature difference. Paresthetic. So is the patient experiencing any pins and needles or numbness, which can also indicate any nerve changes or neuropathic changes, but can also indicate ischemic changes there. And paralyzed. So is there any changes in their mobility of their foot? We'll also look at skin changes. So with reduced circulation, you can get certain skin changes. So the skin tends to be quite shiny, almost like that tissue paper thickness. You can get atrophy of the subcutaneous tissue. So a lot of the times you'll see, you can really see the sort of the blood vessels underneath the skin. You can see the structures, you can see the tendons and everything. Is there any hair? So it tends to have less hair or no hair on the foot when there is a poor blood supply. And again, the temperature gradient and anhidrosis, which is dryness of the skin. So typically in an ischemic foot, you'll have a real dry foot. There'll be some fissuring potentially around the heel, so some like heel cracking around the back. It'll just be a real dry, flaky skin. We classify ischemia in 2 categories. So you can have critical, where the skin tends to be a dusky red colour or have a bluish discolouring. And acute, so if there's potentially a deep vein thrombosis, and you can get that paleness, or you can get that purplish mottling kind of colour. So palpating the pulses, as well as appearance, we'll try and palpate the pulses, and within NELFT, we'll palpate the dorsalis pedis, pulse, which can be found on the top of the foot, generally in between the first and second metatarsal, and then the posterior tibial, which is located just behind the medial malleolus, which is the inside ankle bone. It is worth noting, though, about 10% of the population have unpalpable pedal pulses, and other factors can reduce the likelihood of being able to feel that pulse. So if there's any edema present, then it does make it harder to feel that pulse in the foot. So here you can see some pictures here on the left-hand side. That's someone palpating the pulse. So the top left is the dorsalis pedis, and underneath is the posterior tibial. And on the right-hand side, you've got the Doppler, so the handheld ultrasound device, which would use to listen to the waveforms within each pulse. So neurological assessments. So we'll carry out a neurological assessment using a 10-gram monofilament, which is what you can see in that picture there, which looks like a bit of fishing wire, but it's quite a technical bit of kit, really. So the monofilament is tested on the site, so we can see the red dots there. So within NELFT, we'll test it on the tips of the big toes and the third toe, and then 3 sites underneath where the balls of the feet are. And you would press that against the skin till it buckles. So you'd press it in about 1 centimetre. The filament shouldn't be bounced, but it should just buckle within that 1 centimetre. We'd then ask the patient to either look away or close their eyes. And if they can feel it, that's a sign that they've got a good sensation in their feet. If they can't, it can indicate that they've got some neuropathy there. It is worth noting that if there is any callus, which is quite common in those areas, if there is any callus there, then it may give you a false positive, because it does reduce the sort of sensitivity of the feet if there's a bit of hard skin there. Neuropathy is diagnosed if there are 2 or more areas on the feet where the patient couldn't feel that monofilament. Okay, so neuropathy can be split up into 3 categories. So you've got autonomic, motor, and sensory. I'll give a brief description of these of neuropathy, and then I'll allow Ibrahim to come in and do his presentation. So autonomic neuropathy is it affects obviously the autonomic system, and quite often you'll find really very dry skin. As you can see in that picture, you've got that fissuring there, so it's that cracked skin around the back of the heel. With these cases, we will reiterate the importance of moisturising those feet daily, particularly with a urea-based emollient, because it will put a bit more moisture back into the skin. But patients with that dry, cracked skin will need to moisturise the skin every day, if not twice a day, 3 times a day, if it's still really dry. And that's just to put that moisture back in, because if you've got dry skin, it does lead to an increased risk of it fissuring. It can ulcerate. You've then got an open wound, and it increases the chances of infection. So a bit of daily moisturiser should help prevent that. So we advise it all over the foot, on the top, underneath, around the heel, just not in between the toes, because if you put more moisture in between the toes, it's then warm, dark and damp, and it does then increase the likelihood of developing athlete's foot of fungal infection. So yeah, everywhere over the foot, just not in between the toes. So sensory neuropathy. So this can lead to a lot of different sensations in the foot. So patients will quite often describe it as feeling numb, or their feet feel cold or like blocks of ice, when actually to touch they're quite warm. You can get tingling and pins and needles. Sometimes patients will describe a real shooting, all of a sudden come out of nowhere pain, or a burning hot sensation when again they're not warm. And this can, particularly, patients will generally describe those symptoms more so of a night time as well. And obviously if that patient's got numbness, that can lead to unknown trauma, which, you know, if a patient could have trodden on something, they've not been aware, that's caused damage to the foot, and that then can lead to ulceration, infection. It can deteriorate from there. I think the best thing I found in someone's shoe was a bunch of keys. That's my record so far, which he was unaware of. And so here you can see from the picture, that's the big toe. You've got a bit of hard skin, but you've got that staining within it. So it's what we call extravasation. And that just indicates that there's such a high pressure within that hard skin that it's caused almost like a bruising or a bleeding within that hard skin plaque. So as podiatrists, we would debride that callus and look to try and offload that pressure to reduce that likelihood of the callus developing and reduce the likelihood of ulceration from occurring. And motor neuropathy. So this can lead to foot deformities, with the classic being a real high arched foot. So you can see in this photo here, it's got a real high arched foot. The toes tend to retract backwards. So then you end up with real high pressure points underneath the balls of the feet and on the tops and the tips of the toes there, which wherever there's high pressure, it does then increase the likelihood of developing ulceration. So as a podiatrist, we would debride any hard skin that was developing on that foot and then look to give footwear advice or give bespoke footwear or an insole that's just going to try and distribute that pressure and take it away from any high pressure points there. Again, that's a classic deformity that we'd see within podiatry. So that's a claw toe, which again can lead to callus formation on the top and the tip of the toe. Ibrahim, do you want to come in with your presentation now? And I'll come back to mine after.
Thank you, Lauren.
Yeah, I'll stop sharing. There you go. Right, over to you, Ibrahim.
Right, can everyone see?
Yes.
So just coming on from Lauren's presentation. So orthotics and offloading the diabetic foot. Okay, so orthotics play a very important role in treating current foot ulcers and to prevent re-ulceration, so of a long-term management plan. They provide stability, limit the joint movement, and controlled foot deformity. They relieve the load and evenly distribute the pressure on the foot. And these devices can be very simple with a bit of chairside modification or semi-custom to fully bespoke. So as you can see, so a chairside modification insoles, which takes a fairly simple insole, for example, one of these ones, and things could be applied, whether sort of EVA, metatarsal dome, different materials on top of it, pour-on, memory foam, to make it a little bit more bespoke to the patient's foot. So for example, if they have a third or fourth joint ulcer, applying a bit more of a pad to particularly take off the pressure around here could improve the treatment plan and also prevent it from re-ulcerating. So custom orthotics are a little bit different. That takes an imprint of a patient's foot. So this is a bit more of a foam box imprint. Here is a plaster of Paris, and a little bit more sophisticated, you're looking at a dynamic foot mapping. So most commonly in NHS, the foam box and plaster of Paris is a bit more reserved, or they have access to it. And in the private practice, you may get a bit more of this. Bear in mind that custom orthotics, they're quite expensive. You're looking about £180 for a set. And if these things need to be modified again, there's probably a cost to that. Furthermore, in addition, when we do orthotics therapy, it can be a bit of a trial and error. So first time we do it, it may not be a complete fix. Perhaps we need to review with the patient how they've responded to the materials, how they find the device itself, and whether what we're trying to achieve, for example, their fourth joint, does the device take away the pressure adequately. So offloading using a pneumatic walker air cast boot, probably you see that more for people that have a Charcot foot. The idea is it acts very similar to a total contact cast, but it can be removable. Within the air cast, you have little pockets where you inflate Once inflated, these sections hold the foot and ankle in position, limiting the motion. The boot also offloads the plantar aspect of the foot by achieving total contact with the plantar surface of the foot. Therefore, it redistributes the force and pressure and as widely as possible across the entire plantar surface. Now, it's important with these devices, first of all, we need to ensure that patients know how to use them correctly. So we need to show them how to use it. And also a bit more, depending on how long they use it, patients can feel a little bit lopsided. So it's important to address that as well. We may need to add another insole just to give them a little bit of a lift on the other side. So at the very least, footwear is very important to reduce re-ulceration. Most patients, well, some patients may not like the idea of insoles or orthotics. If not, at the very least, they want to be wearing a good quality trainer which offloads or cushions the foot very well. They really need to stop wearing or try to encourage them from wearing these type of shoes that are very flat. Because if you imagine, if their shoe is very, very flat and they've got a prominent metatarsal head, then that there's going to be an increased pressure just under that joint, and the skin's going to break down, causing an ulcer. So it's important to address all of that. And thank you, Lauren. I'll pass that back to Lauren. Stop sharing.
Thanks, Ibrahim. Right, I'll just bring my presentation back up. Let's just find where I was. Can everyone see that?
Yes.
Fab. So yeah, I left of the one of the deformities that we would see. So this is a list of common deformities. Obviously, it's not an exclusive list, but it's sort of the common deformities that we would see as podiatrists. You've got clawed toes, pes cavus, so that describes that real high arched foot, which has the increased high pressure points underneath the balls of the feet, tips of the toes, tops of the toes. Hallux rigidus, that's a real stiff big toe joint that doesn't move as it should do during the usual gait, or hallux valgus, which is the classic bunion deformity. We often will often see a loss of fibro fatty padding underneath the foot. So say if a patient's got a clawed toe, that tends to pull the fibro fatty padding that we get underneath the balls of the foot. That then leaves the balls of the foot exposed, and again then increases that pressure underneath because they haven't got that nice soft padding underneath the foot. We have hammer or mallet toes, Charcot foot, which I'll go into a bit more detail next. It can be deformities that are related to trauma or surgery. So if a patient's had a digit amputated, what you'll quite often find is that the other digits will move to fill in that gaps, and that can then cause other deformities to the digits or foot. Or nail dystrophy. So if the nail has become misshapen, quite thick, that can cause trauma to the nail bed underneath, and that then can itself lead to ulceration. So Charcot deformity, this is a serious foot condition which can lead to significant deformity to occur. There are 3 stages. It's the acute phase that will quite often present as a red hot swollen foot, usually with pain, which is unusual because it would be patients that have neuropathy that develop a Charcot joint. So if the patient's coming in with a red hot swollen foot and they're saying it's painful, that sends the alarm bells ringing. Second stage is the bony destruction, where the deformity can occur. So that all depends on which joint that the Charcot is occurring in, but it can lead to certain deformities to develop. And then thirdly is a consolidation phase. So this is where that bony destruction stabilizes, but that patient's foot can be left with a real significant deformity. So the acute phase, so as you can see, it's a red hot swollen foot, but obviously there are differential diagnoses for that. So it could be a Charcot, but it also could be cellulitis. It could be a deep vein thrombosis or gout or a soft tissue injury or a bony injury occurring. Is there a history of trauma? So generally with Charcot, there isn't always a history of trauma. There can be. It could be that a trauma has then ignited this Charcot to occur, but generally there's not too much of a significant trauma that's happened to the foot. And so that's really important that we take that real in-depth history to find out how long that red hot foot has been occurring, what are they doing the day of, how long does it last, is there anything that makes it better, anything that makes it worse. So as you can see from that photo here, the deformity can be devastating. It can lead to ulceration. So you can see the whole arch of the foot there has completely dropped down and is now lower than the rest of the foot. So when that person's now walking on that foot, they've got a real high pressure underneath the arch of the foot, and that's then led to that ulceration to occur underneath the arch there. So as podiatrists, we will offload that foot with, as Ibrahim said, with that air cast boot initially. So we'd send that patient, so if a patient comes in and we're suspecting a Charcot, we would straight away immobilize that foot to try and prevent any of that deformity from occurring. Within Delft, we would then refer that patient to King's College Hospital. So that's a centre of excellence for treating Charcots. And if they confirm that it is a Charcot, generally they can do it either on X-ray, but doesn't always show up. So they'd want to do maybe an MRI. Once that is confirmed, they would then look to put that patient into a total contact cast until that Charcot has stabilised, which can be quite a long process. We've had patients that are in casts for up to sort of 18 months, 2 years, until that bony activity has subsided. So here is an X-ray of a Charcot. So you can just see there's no clear definition in the joint lines. You've got that real fuzzy appearance around all those joints. It's just indicating how much bony activity is going on within that X-ray there. So how often do we perform a diabetic foot screen? So according to the NICE guidelines, the frequency of screening depends on the risk status. So there's 4 risk statuses. You have low risk. So that's when a patient has no risk factors. Their diabetes is generally well controlled. Their foot is, there's no deformity present. They haven't got ischemia or neuropathy. They may have a little bit of hard skin, but it's something that can be maintained with sort of good footwear or good emollient use. Moderate risk is the presence of neuropathy or ischemia or major deformity. High risk is the presence of neuropathy with heavy callus, ischemia with neuropathy, ischemia with heavy callus or deformity, but also if the patient has had a previous ulceration or amputation, they will automatically be classed as high risk. And also if that patient is receiving any renal therapy or dialysis, they would be classed as high risk. And then the 4th category is active foot problems. So that is the presence of ulceration or infection, a Charcot or suspect Charcot, gangrene or necrosis, or an unexplained red hot swollen foot. That patient is classed as having an active foot problem. So if a patient is assessed as being at a low risk, then they will have an annual screening, generally with their within primary care. So if in Delft, if a patient comes in and they're low risk, then we would refer them back to the GP just for their annual screening. So doing the vascular assessments, doing the neurological assessment, if anything gets flagged up, they can re-refer, but they would be seen by the primary care. For moderate risk patients, is every 3 to 6 months. High risk is every 1 to 2 months. And active foot problems is every 1 to 2 weeks, or if there is any change in the foot, so if they develop a new ulceration, then as part of that, we should be doing that assessment. So this is a nice clip from the Diabetes UK website. So it just breaks down those 4 categories, what makes that 4 category, or makes each category, and then what we should be doing in terms of looking after that patient with sort of a low risk or moderate risk. So when to refer, who they should be seeing, how often they should be seen. And that is how to perform an annual foot review. So obviously asking the patient to take their shoes and socks off and looking for any deformity, asking about footwear, looking at their shoes that they're coming in, and just giving good advice there. So it's an exciting time within podiatry in NELF. So we have developed a new service called the Diabetes Foot Protection Service. Historically, within podiatry, we could only treat patients who had high risk feet or they had an active foot problem. However, we were seeing a high number of ulcerations and amputations. So we've developed a service that allows us to see patients with diabetes who are assessed at being a moderate and high risk. As I said before, low risk will still be seen annually by their GP. An active foot problem. So if a patient has got an active foot ulceration or a Charcot, they'll still be seen within the existing podiatry team in the community. But anyone with moderate or high risk, we can now see them a lot earlier. And it's just about preventing the ulceration and amputation occurring, because we're seeing them a lot earlier. We can try and nip things in the bud, basically, because prevention is always better than cure. And prevention is better than cure, isn't it? So the foot protection service is still in its pilot phase. So we're just going out to a couple of GP practices at the moment. But once we're fully up and running, we've completed that pilot phase, and we'll be sending out details of the service in communications. Okay, so I'm just going to discuss some case studies. A bit of water. So case study 1, patient comes in, he's a male, 14 years old, was diagnosed with type 1 diabetes when he was 3 months old. He's come in, he's been referred because the big toe has been very sore, he can't play football at the time, and he's getting bored. His average HbA1c is 48. So when you take his shoe and sock off, this is what presents. So as you can see, it's quite a nasty ingrowing toenail there. So as podiatrists, what we would do is we'd swab the area to see if there's any infection occurring. We would advise a dry dressing and regular saltwater foot baths, obviously checking the temperature before he puts that foot in, just to make sure that he's not going to put his foot into burning hot water and not necessarily know about it. We'd prescribe an oral antibiotic. We, as podiatrists, don't tend to advise topical antibiotics. We'd always go oral antibiotics. So the swabs come back that there was a Staph aureus. So we've prescribed either flucloxacin or erythromycin. So within podiatry, if we have an ingrowing toenail, the treatment plan that we use is we would do nail surgery on them. So under local anaesthetic, we'd do a partial nail avulsion. So that's just taking away a section of that toenail that's ingrowing. And we can then put a chemical, if it's indicated, we can put a chemical down there called phenol that will stop that offending bit of nail from growing back. And we would keep that patient on our service, or within the service, until it's healed. Okay, second case study is patient B is a female, 65 years old. She's come in saying her toenails are digging in and they're thick. When you screen the feet, you find no obvious risk factors, but you observe the footwear and they look like that. Which, you know, we do see shoes coming in all shapes and sizes, and that's obviously not going to be good for the foot. But no, this is the real foot. This is the real shoe that she's come in wearing, which is a classic narrow toe box. It's got a heel on there. It's not a good style shoe to be wearing, particularly if you're complaining that your toenails are digging in, because it's going to really pinch across those toes and exacerbate that pain that she's getting. So the action plan for her would be to give a real in-depth advice plan on footwear and socks. So we'd advise her to wear a deep and wide-fitting shoe, preferably with a fastening, so something that ties onto your foot with a lace or a Velcro strap or a buckle, just so it holds that shoe onto the foot better. We'd also give self-care management, so how to cut nails properly and correctly, and how often she should be doing that. But also, if she's still unable to cut her toenails successfully, then she could always see a private chiropodist or podiatrist. So she wouldn't actually be eligible for the service because it is just toenail care. case study 3. So type 2 diabetes. She's female, 65 years old. HbA1c was 78. She doesn't regularly test her own diabetes, and she's presented with ulceration to the left foot, 5th toe, post-trauma. So she's knocked her toe and it's left her with a wound that's not healing. It has a sausage toe appearance. So it's that real red, swollen toe. Technical terms, a sausage toe. And has been on a 10-day course of flucloxacillin. And this is her present regime for her diabetes. So yeah, you can see from that photo when we describe sausage toe, it is that cellulitis of the soft tissues. It's affecting that 2nd toe there. But it's a real obvious size difference, colour difference compared to the others. So for her, because she has that sausage toe appearance, we would send her to the acute team for management, because if a patient's got that sausage toe appearance, you would worry that there's some bone infection or osteomyelitis from occurring, or could be occurring. So we'd send her to the acute team, and they'd look to x-ray the foot, and vascular or the diabetes consultant may prescribe some antibiotics if they do suspect there is some bone infection going on. She'll also have some diabetes management input, some vascular input. So they would look at her blood supply and see if there's anything they can do if there's any issues with her circulation. Radiological assessments, as I say, that she'd potentially have an x-ray there. Intravenous antibiotics if it's indicated. And we'd potentially refer to the integrated diabetes service for diabetes advice, just so we can improve her diabetes control, because that's going to help her overall health, but also help the healing of her foot there. So she ended up that the pathology was successfully treated with antibiotic therapy. So she had co-amoxiclav. She's still under the vascular team, so they were having regular checkups. She was referred and taken on by the integrated diabetes service, and that's improved her diabetes control. So again, her overall health will be better, but also her foot health will be a lot better as well. Okay, so this is just a slide about the podiatry services. So the service provides both clinical care and health promotion for a wide range of medical problems affecting the feet. So obviously diabetes, but we also do treat patients that have rheumatoid arthritis that has affected their feet, other conditions, if they are ischemic without being diabetic. So we provide wound care management for foot ulcerations, management of bone and muscle problems. So we look at biomechanics. So for example, if there's any heel pain or flat feet, sports injuries, then we can provide insoles for that. And we also provide toenail surgery for ingrown toenails or painful, problematic toenails. So we have clinics in Porters Avenue in Chadwell Heath in Barking and Dagenham, Harold Hill, Cranham, and South Hornchurch within Havering. So who is the service for? So people over 18 years old, but we do treat patients who are younger for toenail surgery and biomechanics. We don't treat verrucas, and we are now providing that diabetes foot screening as part of the diabetes foot protection service. So referrals are done via the GPs or healthcare professionals. Referral form is available for Barking and Dagenham, and for Havering patients, it's via SPA. So we no longer accept self-referrals. Our service times are Monday to Friday, 8:30 till 4:30, and we're not available through Choose and Book. And this is, so when we get our referrals forms through, quite often we'd have to send them back for these sort of problems. So if there's no details of an active foot problem, for a verruca, if it's just requesting toenail cutting, we do cut toenails as part of an overall package of care, but it can't just be purely for toenail cutting. Or for leg ulcers, that would be referred to the nurses or the leg ulcer nurses. And that is our address there for our head office. So that's over at Chadwell Heath. Okay, is there any questions? I'll stop sharing and then I can see everybody then. So yeah, that in a nutshell is diabetic foot screening. So what patients would expect to to have when they come in, or if they're referred to podiatry or the Diabetes Foot Protection Service.
Thank you so much. Thank you so much, Lauren and Ibrahim. Yes, please do ask questions if you want, either in the chat, or you can unmute yourselves if you have anything to say. Please don't leave immediately without asking questions or filling in the very famous, as you know, the feedback survey. Most of you are very familiar with this. Let me just put it up. I'm going to put it in the Zoom chat. It'll take 5 seconds, 1 minute, not even a minute, like literally 5 seconds. It's multiple choice. The only thing you have to do is write your name. The others you just have to choose from a row of options. Can everyone see it in the chat? See the feedback form? Great. Any questions? No, I think they're ready for the quiz then. I'll stop recording.